if you do ultrasounds on people, it's probably at least half the population has vein abnormalities. Now, only a minority of people have problems and need a treatment. So it's not something that you're predestined to need a vein treatment. But certainly, if you have symptoms and and the symptoms are as you've described, and there are a few others too that are big ones, those people really do get a benefit.
Welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is Dr. Michael Ryan. Welcome to the show, Michael.
Yeah, it's good to be here. Thanks for having me.
What a pleasure it is to meet you. Michael is the founder of the Missouri Vein Care. What would you call it? Missouri Vein Care
Clinic.
Clinic. All right.
Yeah.
And your website is MissouriVeinCare.com.
Correct.
Michael has an incredible story. He went undergraduate at Harvard. He went to medical school where in Minnesota?
Columbia University in New York.
In University of New York, in New York City. Did a general surgery residency in Minnesota. And then went off to the prestigious Heart Institute, Texas Heart Institute down in Houston. And he actually trained with Denton Cooley.
Yes, that was one of the highlights of my medical training. I'll tell you, it really was a remarkable experience, and what that has stayed with me to this day.
Yeah, so, widely regarded as perhaps the greatest cardiac surgeon, at least up until that point. Very famous. So you must have been an incredible resident to get that kind of position, Michael.
Well, yeah, it was competitive, and I was very, very pleased that I was selected. There's no question about it. And to work with Dr. Cooley and his team, because he selected a group of like-minded and similar skill level individuals. So it was really a very special opportunity.
So you got tapped to work with Denton Cooley. That's really amazing. So you then started practicing cardiothoracic surgery in Oregon, and then you came to Missouri. And then something might have happened that caught your interest in the world of vein care. Tell me that story, Mike.
Well, okay. So what happened is I got exposed to the advances in treatment of vein disease as a resident, and you may or may not have been exposed in your training to vein stripping. But vein stripping was the standard of care for decades. As we were training, and vein stripping was very painful and very, had lots of complications, and people were laying around for weeks because of the pain. They got blood clots. Some people died. It was terrible.
What is vein stripping?
So vein stripping and vein stripping, I can explain to you, but I will also say that vein stripping lives on today because people won't come to see me because their grandmother or mother had vein stripping, and they say, I never want to have something a bad like rap. That. So they assume all vein treatments are vein stripping, which of course is not the case because vein stripping is rarely performed. But vein stripping is what would be described as although it's an open procedure in that you make an incision in the groin and an incision at the ankle to expose the great saphenous vein. At that point, you put a long, flexible plastic tube into the vein and pass it up. You tie the vein to this tube and divide the vein from its connection to the circulation, and then you yank out under force.
Oh, so it's just as bad as it sounds.
It's very bad, and it's very painful. And that what I learned from doing cardiac surgery is that when we, in the evolution of harvesting the great saphenous vein from an open incision along the whole leg to tiny little incisions, and then the endoscopic technique where we had one incision at the knee and one incision at the groin, and we were able to go up and dissect all the branches off and divide the branches. There was essentially no pain. So the pain came from what is really a traction nerve injury. When the vein is pulled out with vein stripping, the saphenous nerve is attached to the vein and is yanked out, and then that traction goes all the way up to the spinal cord. And the pain lasts weeks and weeks and weeks. It's absolutely miserable pain. So that that's why it was such a terrible procedure.
So people may not know this, maybe they do, but when you do a bypass procedure and you're trying to bring in new blood flow to the heart,
Yes.
frequently you'll harvest this vein from the leg as a conduit. It's called a graft. So you already had experience with the saphenous vein,
Yes.
harvesting it.
Yeah, every day of the week. Yes,
Every day, all
yes,
day.
Yes,
Yeah.
and I saw normal veins and abnormal veins. The abnormal veins we couldn't use for bypass because they were associated with developing a clot in the vein and a heart attack in the immediate recovery period. So we had to use normal veins. The kind of veins I treat now are not normal.
Right.
So they're very abnormal.
Right. So tell me more. So what caught your interest in vein treatment versus cardiothoracic surgery? Well, that's a real lateral shift, Michael.
Yeah, well, so I was exposed to the new technology which was developed in the first endovenous, as it's called, which is a technique which is basically through an IV placed in the vein, was performed in France in 2002. In 2005, it had reached a level where it was approved by the FDA and there was commercial products available. And a salesperson came to my office and explained how this might be a benefit to some of the patients.
Are these sclerosing agents, these foams? Am I getting that right?
Well, this is a technique that's called endovenous ablation. So it's a technique where it's done percutaneously, which means an IV is placed through the skin into the vein.
Okay.
There's no incision, and inside the vein, a small plastic tube or catheter is placed, and you can use a variety of different of modalities. A laser or radio frequency are the two. The end result is it delivers heat to the inside of the vein. It's, of course, all numbed up. So the heat causes the vein to shrink down, and the fundamental problem is that the circulation is not flowing, and there's stagnant blood in the veins, and that stagnant blood triggers all the symptoms.
And we're going to get into all those symptoms.
Yeah.
I want you to explain this for our audience so they understand what
Sure.
these symptoms are and how they can be treated. So I'm just following the story here. So there was a new way to get energy inside the vein. You didn't have to strip them anymore. You could go in and essentially get rid of the vein or close it up.
Right.
And that caught your interest.
Right. So I talked to the rep, and the rep made the case that this is something that really can benefit people. And I said, okay, I have time in my schedule as a cardiac surgeon for one afternoon a week to do something in the office. So, and I certainly had plenty of patients that I saw that would be candidates. So I picked a couple of patients and I explained I've never done this and I'm going to try it.
You're my first one.
And do you want to have a opportunity to get some improvement? And I told them I'd researched it and thought it was of benefit.
Right.
And it was an immediate improvement for these patients. Immediate, and that as you as a physician know that we live in a world of the double-blind, randomized, controlled prospective trial.
And unless you have that, they don't regard it as evidence.
Exactly. And in my opinion, having done research for several years as part of my general surgery training, what I concluded is that at some level, that entire complicated scientific validation method doesn't necessarily apply to clinical medicine because all of the controls that are part of the study cannot be reproduced in a clinical practice. And so really, I feel at some level, if you have an intervention and you see with your own eyes, this is helping, that counts.
It does count. And there's a famous article in The Lancet 20, 30 years ago talking about parachutes. Well, we shouldn't use parachutes because there's never been a double-blind, prospective, controlled study on parachutes. Yeah.
So so this method has been validated by a lot of studies, but it was clear to me within a week that this was benefiting patients. They said, "Oh yes, I feel better. Thank you."
And your skill sets as a cardiovascular surgeon, it would really fit right in.
Yeah,
you already had the skills.
Yeah, there was no additional skills to learn, really.
Right.
So it was a natural addition to my practice. So I started performing those treatments one afternoon a week, and then it increased to one day a week. And then because there was obvious benefit and there's word of mouth, people were talking to friends and families, and so all of a sudden I had more patients. And the other part of the equation is that I've had a vein condition since probably since I was in high school, because I had a bulging vein on my leg in high school, and I could look at it, and I knew that wasn't normal. But it didn't really hurt me. But when I was in medical school, I still remember the moment when I was at the scrub sink scrubbing away, and I looked to the resident, who's a cardiac surgery resident, Dr. Franco, and I said, "My legs are just killing me." And he looked over me and said, "Well, you have a vein problem, and you need to start wearing compression stockings."
He knew he couldn't see your leg. He just knew.
He just knew right away. And sure enough, I was in such misery that I immediately grabbed some TED stockings and started wearing them, and I immediately felt improvement. So I've been, that was when I was 25 years old. So
you should be full of vigor and strength, and you're peaking then.
And I can remember that was in medical school. Then I went to residency, and I can remember in Minnesota, I was at the Minnesota State Fair and I was a very athletic, person. I was in a competitive rowing program, club level at that point, but I was in great shape, and I can remember walking around the Minnesota State Fair, and my legs hurt so bad I had to lay down on the cement and put my feet up on a bench
to get the pressure
off my legs, because they hurt so bad. And so, the long story short is, I have had a vein condition for a long time, and so I've had treatments, and I saw what a huge difference it made for me, and so. There it was. I'm like, gosh.
There you go.
Yes.
So you're helping people, and you've experienced the benefit yourself. So when did you just transition out of cardiothoracic and say, listen, I'm going to go full time. I'm going to start the Missouri Vein Care, clinic?
Right.
Well, when did that happen?
So in 2007, I realized that there was such a demand for this kind of service. And I was seeing, at that time, I was a little bit confused about why this helps people so much. I didn't completely understand it. Now I have a much better understanding. But the other thing that I didn't understand that was new to me was how the psychology of people was changed. And as physicians, we don't really learn much about psychology. We learn about psychiatric diagnoses in medical school, but we don't really learn. I'm sure in your practice you have developed an understanding of the psychology of the conditions that affect your patients. But in cardiac surgery, there was a little bit of a understanding of the psychology of primarily people facing their own mortality. It was life or death. It was fear. It was denial. And I saw all kinds of remarkable stories that related to that. Vein care was different. In fact, I'll tell you one story that showed me how dominant this psychology of the fear of death was. And there was a lady I was asked to consult on and do a bypass surgery on the next day, and she happened to be the pastor. She was a nurse at the hospital. I'm sorry, a nun at the hospital. So that was her role. She would go around. She was a constant presence, and all of a sudden, here she was, a patient. And I came to see her. It was late. It was 9 o'clock because my day was long. And I came in to see her. And this was always the most genteel, kind, pleasant, loving individual. And we were always on good terms. And I talked to her, and I would tell her there's a family that needs your help, and et cetera. And I walk in, I talk to her, and she let out a stream of vile and anger and bitterness and yelling at me, and you're coming here so late, and what are you doing to me? And it was, I completely was taken aback. And so I sat and talked to her some more, and then she told me the story. At the very end, she said, I guess I'm just afraid because I was at a mission experience in Central Africa, and everyone in our group was gunned down by the bad guys, banditos, and I pretended to be dead under the pile of bodies, and I was the only one that lived.
Oh, I know stuff like that happened in Congo.
Toledo.
Oh my
Yeah. So
God.
she told. So then I realized that it's the fear that people have makes them do strange things. And
It's called coming out sideways.
yes. So, but the bottom line is that with the fear, people never really were able to express gratitude at a level that you would expect. They're too trapped in their own emotion. And what happened, what I noticed immediately after when I started doing vein treatments, and it took me like a year to understand what's going on, is that these people came back and they were bubbly and happy. They were like happy, and you're like, what kind of snake oil salesman is going to tell people they're going to get happy after vein treatments? And I didn't understand really what was going on, but it's a very predictable reaction. And I think the basis for it is there's two things. One is I learned more about the psychology of chronic illness. And, not every physician deals with chronic illness. And I never really had dealt with chronic illness as a cardiac surgeon. It was all acute. But chronic illness is characterized, I think, by the dominance of the primitive brain, the limbic system, as we call it. The emotional portion of the brain is responding to chronic illness. And that is, I think, also characterized by very concrete thinking, permanent thinking, and all-encompassing thinking. It's completely consumed, and there's no way out of it. There's no escape. And I give people the example of the times when you have had a cold for 3 weeks, and how do you think about it? You say to yourself, "I'm never going to get any better. I'm never going to. This is just completely consuming me. It's defeating. So people have that reaction at the limbic level to chronic illness, and so they have that. And plus, I believe that and then part of the psychology of that is a sense of hopelessness and helplessness. There's nothing you can do about it. When people have that psychology, helplessness, hopelessness, that is the substrate for depression. So people have it, and even though they may not be clinically depressed, they have a quality of depression about them. Superimposed upon the psychology of chronic illness, as I was learning about it and helping myself understand what these patients were going through, the condition of vein disease actually has its primary problem is related to inflammation in the body. And inflammation poisons the body's ability to generate energy, and people feel exhausted. And in a way that I don't understand, but I think it's very true, people with chronic illness that have inflammation as part of the basis of their condition. And I give the example of when you've had a viral syndrome for 4 weeks, which people go through periodically, they feel kind of hopeless, depressed, frustrated. But then there's a moment if you've had this and you think about this, where in your viral syndrome, that all of a sudden within a span of 24 hours, you go from being exhausted, frustrated, to being exhilarated and like larger than life. You have more energy. And
boy, I feel better now.
Yes, I can do. I'm feeling great, and there's a elevation of the mood that's accompanying that. So I think that is when the inflammatory mediator levels in the body begin to abate, and people are, because I think the inflammatory mediators do have a direct impact on psychology.
Oh, you're absolutely right. That's very insightful, Michael.
So I began to see this in these patients, and it took me a while to understand, a year of pondering and asking and reading before that's my conclusion. And there may be other perspectives from other professionals that could clarify it more than me, but that's how I put it together, and it makes sense from what I see. But anyways, it was remarkably satisfying to treat people and have them come back, and they didn't even have to say thank you. You could by simple mirroring of their emotion, feel their happiness and their excitement and enthusiasm. So, and my staff is aware of that too. They like these patients. So that was. When I began seeing that, I thought, boy, there's something nice here. There's something really nice about this, of what we're doing. We're having an impact. And this is a group of people that is we're helping, and they have through their elevation of their mood and transformation of their psychology, they affect everyone, including myself and my staff.
Yeah, it just snowballs.
Yes, so it's a good thing.
That's wonderful, and clearly you're helping a lot of people, Michael, because now you have 3 clinics.
Yes,
you're expanding.
Yes,
and your reputation is fantastic.
Yeah.
So what a wonderful development or evolution of your career. Wouldn't necessarily predict it, but boy, makes a lot of sense. So let's talk about these various conditions.
Sure.
I read your materials and your website and whatnot, and clearly if you've got a big bulging vein or it looks like a bag of worms in your leg, anybody can recognize that. Or you've got the spider veins. I've got a couple of those myself. Clearly that's abnormal. But you also talk about things you can't see. And is it usually the legs more than the arms? Are the legs the primary place?
The legs are almost exclusively the domain of venous insufficiency or vein reflux, this abnormal circulation that we treat. But the arms are almost never involved. If they are, you have to be concerned about something going on near the heart in the vena cava or the subclavian vein. That can be what's called subclavian vein syndrome, thrombosis, or it could be an IV catheter for someone getting cancer treatments or other treatments that is clotted off a vein.
Gotcha.
But arms are really not where we see a problem.
So it's mainly legs.
Yes.
So we've got these visible things, and apparently the skin can break down. It can change colors. You can get sores, what they call ulcers or stuff. But then you describe things that was really eye-opening to me. The legs can feel achy, restless. You can have fatigue. You can feel cold, burning, stinging, itching, cramps, Charlie horses. Tell me about all these various symptoms that can obviously run you down, can affect the quality of your life. So talk about these symptoms that someone might be experiencing, when they should start thinking, gee, I might have a vein problem and I should go see Dr. Ryan.
Well, it's a very common problem in terms of if you do ultrasounds on people, it's probably at least half the population has vein abnormalities. Now, only a minority of people have problems and need a treatment. So it's not something that you're predestined to need a vein treatment. But certainly, if you have symptoms and and the symptoms are as you've described, and there are a few others too that are big ones, those people really do get a benefit. And the symptoms can be broken down into, in my thinking, into symptoms of the legs and feet, neurologic symptoms, and then what we call in medicine constitutional or systemic symptoms.
Okay, let's break those down.
Yeah, so the leg symptoms are generally swelling, aching, heaviness, throbbing, and there can be burning pain as well. The burning pain seems to be more associated with an actual patch of veins. By the way, most people, I would say 80% of people, don't really have very visible abnormalities on their legs. So, and this is a problem with the lay public and also the medical community, because there is a misunderstanding that to have a vein condition means you must have an abnormal visible vein, and in fact, only 20% do.
That's a very, very impressive number there, Mike.
Yes.
I did not know that.
Yeah. So, and that is results in a very frustrating pattern that we see again and again, in which the patient has gone to their primary care physician, who reassures them, there's nothing wrong with your legs. There's nothing. I don't see any problem there. Or maybe advises them to wear compression stockings and there's nothing really to do. Or the most I would say frustrating and depressing for the patient is when they're told, you're just getting older and put up with
accept it. Right,
yeah,
right.
When in fact it's something that's very treatable, can be improved. So,
well, I have a parallel in my world. It's called endometriosis. Women have this horrible pain, and they just blow it off. They poo-poo it, and it takes 7 to 9 years to be diagnosed on average. They can't see it. Says, oh, it must be nothing, or just live with it. It's normal, honey. Right? They patronize it. So people with vein problems get blown off as well because they can't see it. That's a pearl of knowledge right there, Michael. So somebody has these symptoms, don't necessarily have an obvious vein. What else can they be experiencing?
Well, so the leg symptoms are very common. The other is the neurologic symptoms, and that is something we see every day of the week, and they are primarily in the feet: burning, stinging, tingling, numbness, cold feet.
And it's not diabetes.
It's not diabetes.
Usually you think diabetes.
Right. And unfortunately, many patients have been told you have neuropathy. There's nothing that can be done to help you. And the clue, the differentiation between the foot symptoms that are neurologic and neuropathy is a constant symptom pattern. It's the same in the morning as in the evening. And with the vein condition, the inflammatory mediators, which are responsible for all the symptoms, build up and are amplified as the day goes on. There's a cascade.
You're standing up, there's more pressure down there.
Right. And so by the evening, there is a amplification of all these mediators of inflammation that are responsible for the symptoms. And so people have a clear pattern of it's worse at night. It's worse in the evening. Mm-hmm. So that's how we have a pretty good idea of whether there's neurologic symptoms are related to their veins. Obviously, they have to have a vein abnormality that we see when we examine them with an ultrasound. But so that's one group that really does suffer unnecessarily and gets benefit. There's another category which is what we call constitutional or systemic symptoms, which primarily revolves around fatigue, and the fatigue is that is of all of our symptoms, the symptoms that we see, that is the single most common symptom of all patients that come in to see us.
I'll be darned. Who would think that something is so vague and we call global?
Yeah. Now, I will say that people start out, vein conditions like myself, like for me, started when I was in my 20s. And I had, physical reserve. I was in great shape. I was exercising, et cetera. And so a lot of the constitutional symptoms didn't really affect me until I was older. And that takes time as your physical reserve kind of slowly declines with age. The vein condition slowly worsens with age. And at a certain point, the symptom of fatigue begins to dominate. And so but for most patients, they have that fatigue, and the pattern is the same for all the symptoms, which it's a fatigue pattern that's present in the evening.
Well, that's another pearl, Michael. You think of fatigue as just being run down, or you're ill, or you've got some thyroid problem or something. Right. It can, in fact, be inflammation from your legs, from venous disease.
Yeah. So the fatigue from those other things like heart disease or autoimmune conditions, thyroid disease, those are constant, and sleep apnea is another one, constant throughout the day. And it's not noticeably worse at the end of the day. And so those are not generally related to a vein condition, those conditions causing fatigue. But
so it's not that you're just getting old and tired and you had a long day. It's you may be getting older, but this vein problem is worse.
Exactly. And it's so predictable that my staff, they participate in doing vein screens. My staff can hear the story and tell them, "Oh, you have a vein condition, and you're going to get relief and improvement."
It's so repetitive.
It's so predictable.
And predictable.
Unfortunately, it's not a symptom pattern that has really been described in the vein literature. But it is so clear cut that it's the way that I can see a patient, and I won't advise treatment for everyone on that basis. Some people I'll say, I think you need to try something different because I don't think a vein treatment is going to solve this problem. And most of the time that's correct, but sometimes they come back 6 months later and we will do a vein treatment and see if it helps them, but not off the bat.
Well, this is, I'm learning so much. So, Michael, somebody comes to you with these symptoms, there's a suspicion one of the doctors in the area knows about you, sends a patient to you. How do you evaluate someone?
Yeah, so the valuation is done in the office. But one thing I wanted to point out about this fatigue is that it is the end stage of the fatigue is weight gain. The weight gain is part of the constitutional symptoms that we see. Weight gain.
Are we talking about water weight, fat weight?
This is gaining weight. This is fat.
Fat.
Yes, and the basis for it is that here's the pattern. The fatigue hits people at the end of the day, and they come home, and it's very interesting. People say, once I sit down, I cannot get up. I cannot get up.
Huh.
And really the basis for it is that the inflammatory mediators poison the mitochondria. That's how it works. And the inflammation in your body has an adaptive purpose, which is you're injured, you've got trauma, and you have to husband your energy and lay in in bed.
Right.
Just like think about the wounded dog or wolf, and they sit for weeks.
They go to ground.
Right, exactly. So it has an adaptive function, but in this case, the inflammation is daily, and it's not adaptive. And so people come home and they're wiped out and they cannot move. And so for 4 or 5 or 6 hours, they are sitting in a chair. And so if you do the calorie arithmetic of house chores versus sitting, it's about 125 calorie difference a day. It's not very much, but if you multiply that times 365 days, it comes out to 10 to 15 pounds a year. And that is exactly how much people gain. 10 to 15 pounds a year.
From the mitochondria. And let's explain. The mitochondria are the energy factories in our cells, responsible for, in a way, let's call it digestion or metabolism of these things. So, and mitochondria are very sensitive to a lot of things. Inflammation is one. We could talk about deuterium and all that. Yeah, mitochondria, very interesting, the electron transfer. But nevertheless, this inflammation, we all agree, will affect your mitochondria. So you feel wiped out. And one way or the other, whatever the mechanism is, you can gain weight, and that's part of the syndrome.
Yes, and that is really a classic. I saw a lady this week. She was 52, and she was just in that state of mind where she's frustrated, depressed, and she ended up gaining weight. And I actually explained what happens to patients, and I explained a little bit about how frustrated and depressed they can get, and she started just crying, because
she's realizing now.
This is what the problem is, and she's gained 30 pounds, and
right?
She doesn't understand why,
right?
Because she comes home and she can't do anything in the evening, and she's going to get a big improvement in her energy, and she'll see the benefits for sure of improved energy metabolism.
Now, I remember in my lobby of my building, one of your clinicians was there with an ultrasound machine screening people for vein problems. So if someone suspected of having a vein problem, they come to your clinic. What are you going to do, Michael, to make a diagnosis of a vein problem?
Yeah, okay, that's a great question. So how do you know that you have a vein condition? Well, the first clue is that symptom pattern, the symptoms and the symptom pattern. After that, we have to confirm the presence of vein reflux, which is abnormal blood flow in the veins, and we use an ultrasound.
Okay.
The ultrasound is done for this particular condition with the patient standing up. That allows the blood to pool in the legs, and you can actually see it much more clearly. And then once we've documented that with an ultrasound, we know where the problem is, what veins are causing the problem, and therefore we can plan how to treat that.
I'm going to make this very simple for our audience. Blood's supposed to leave our heart, down our legs through arteries, and it comes back through veins. And veins have these little flapper valves that assist the blood going back in one direction. But this system can fail, can't it? And the blood now goes backwards. So that's what you're talking about?
Exactly.
You can see that with a Doppler?
You can see that with the ultrasound. That's really the standard method for diagnosing the vein abnormality. So you see the blood flowing backwards.
So you get that on the chart, Mrs. Smith, Mr. Jones, your blood's going backwards in your vein,
Yes.
causing all these problems. So you've got a very strong correlation.
Yeah.
You have a diagnosis.
Right. I will say one thing for people that may be getting an ultrasound. One of the things that we have observed over the years, since we've been doing it for quite a number of years, is that there is what's called a false negative exam. That means the problem is there, but the test is not identifying it. And the scenario falls into two situations. One is the ultrasound is done early in the morning, before you've been standing, before the veins have gotten distended, and
So it can change throughout
Yes,
the day.
yeah.
Very interesting.
and the other is if they go into a cold room, they've got goosebumps. That means their sympathetic nervous system is constricting the circulation, and the veins constrict down, and you can't see the reflux. So those are times when if you've been told by the sonographer, the team, that you don't have vein reflux, but you still suspect it, that's something that could be explaining why it's being missed.
And it needs to be
Yeah.
reevaluated
Yes.
in a different environment, maybe.
Yeah.
Fascinating. So now, can you do that all in one visit? Can you see somebody, or does it take a couple visits, a couple scans?
Usually it works best for us to have the ultrasound and the consult visit on separate visits. And we will accommodate people that are coming from a distance, and we do have quite a few people that come quite a ways. So we try to accommodate them. Generally, we have to have the ultrasound report with the vein sizes and things like that. That it's a more technical requirement to get a plan of care that complies with the insurance. It's how
how
insurance
you have to say,
yeah.
So you've got and like they teach us in medical school, and I brought this up from time to time, we're supposed to get about 80% of our diagnoses from the history. Just if you take the time to listen, usually you've got a pretty good idea what the person has. And then there's 15% from the testing and all that kind of stuff. So you've got their history, you've got is it always sonogram? Do you have any other fancier scans, CAT scans, MRIs, or is sonogram the workhorse?
The sonogram is a workhorse. Occasionally we have a suspicion of a narrowing in the pelvic veins, and we send them for a CT scan. That's a fairly uncommon condition, but it's a condition that has a very reproducible and successful intervention, which is a stent in the iliac vein in the pelvis.
Do you do those?
I used to do those as part of my practice as a cardiovascular surgeon, but I'm not doing any hospital work anymore. So I refer those to other practitioners.
Other colleagues. Gotcha. So you get your ultrasound. We see, hey, there's blood going backwards. There's venous insufficiency. Now, do you ever treat anything that has to do with the lymphatic system? Well, let me explain the lymphatics. It's another way out. The blood vessels, the arteries go out, the veins come back. But then there's this third kind of wispy, hard to see system where fluids come back. Now, how does that work into this swelling? Do you see problems with the lymphatic system as well?
We see people pretty much every day of the week that have problems with their lymph circulation. So it's a very common.
It's common.
It's common that we see it. Patients and referral sources don't know how to differentiate lymph circulation from vein circulation. So they send them to us, and we are able to sort it out, I think, pretty reliably and get them into treatment, which is part of our what we do. But it's the lymph circulation is just as you described. It takes basically, I tell people, it takes the fluid that wants to form swelling in your legs and returns it to the main circulation to eliminate the swelling. When it stops working, you get swelling, and the key features, and in fact, my staff is I think experienced enough to be able to make the diagnosis when the patient's in the room, and then tell me, and I agree with them almost every time. But there's very clear patterns that are very reproducible. One is the swelling never really gets better, maybe a tiny bit better overnight. But the swelling is constant, and that's because you have an obstruction or blockage of the lymph circulation that never is relieved. So is swelling from other causes like heart failure or vein conditions, the swelling gets better when you raise the leg and sleep flat.
Oh, interesting.
Yeah. The other part about lymphedema is the diagnosis of abnormal lymph circulation, is that as it progresses, the swelling goes onto the top of the foot and into the toes. So they have a little hump on the top of their foot and into their toes. That is the hallmark of lymphedema. And that does not occur with other types of edema, because the edema is usually resolved overnight with sleeping flat. So it never gets to the point where the swelling is kind of built up into the feet. So you can Google that and see what I'm talking about, but that's I can look down there and see what the diagnosis is, and get them into a treatment, which is they do respond to treatment, but not a vein treatment. The other thing about people that have lymphedema, or this abnormal lymph circulation, very commonly have an abnormal vein finding on the ultrasound, because it is so common. As I said, over half the population has. So the temptation is, why don't we treat the veins? Just let's treat them. And the problem is that it actually makes the lymphedema worse. So I will not treat people with swelling that have a vein, even mild amounts of vein abnormality. I will put them into lymphedema therapy, because the lymph circulation travels along the vein, and when you treat the vein, it will actually scar the lymph circulation
damage
even more.
The lymph.
So it actually gets worse.
Aha. So what kind of, let's go to lymph, and let me come back to the vein treatments that you do. So what do you do for lymphedema, this poor lymph flow?
Well, they had all kinds of very dramatic surgical treatments in the past. It's only of historical interest, but they
didn't work, which means they didn't work.
It didn't really work, yes. But what's available now is, I think, very effective, and it's done by a trained physical therapist, and it's called manual decompressive lymphedema therapy.
It's a type of massage?
It's a type of massage with a special sequence of massaging the leg, behind the knee, the groin, breathing exercise, because the lymph circulation travels from the foot all the way into the pelvis, into the abdomen, and enters into the subclavian vein behind the collarbone.
Eventually it makes it to your veins.
Yeah, and so the actually part of the therapy is massaging the collarbone.
I'll be darned.
Breathing exercises to massage the circulation. So they have a method, and it does work. It really does work. It takes a number of visits, which is the big penalty for people. It doesn't hurt or anything, but inconvenient.
And they must feel better.
Yes.
Wow. So now you've treated the lymph, and you still see on your sonogram the blood, these veins, or the blood is going backwards. They're not working like they're supposed to. So what do you do about that, Michael?
Well, first of all, you have to establish that the patient is going to benefit from the treatments, and most people have symptoms. Some people also have, they want to have treatments because it has led to the present appearance of unsightly veins, and that causes for a certain percentage of patients a negative body self-image and really negative psychology. Most patients, though, it's primarily their symptoms. They have negative body self-image and negative psychology, but it's primarily symptoms. So once we establish that, the treatments involve closing the veins down. The veins themselves are not functioning. They're letting the blood pool under pressure, and that stagnant blood inside the vein, meaning the blood's not moving, it's sitting there. That is what is triggering this inflammation reaction. The inflammation reaction is causing all the symptoms and the fatigue and weight gain for many people. So we want to close down those veins, and the blood when those veins close down, the blood reroutes to additional veins that are present. Your body has an excess number of veins already in the circulation.
That was my next question. How does the blood get back if you've blocked the veins? Yeah,
so your body has excess veins, and in fact, each year, your body will continue to make more veins. So you'll never run out of veins. Yes. And that's good, because your circulation will always be, adequate. The bad news is that people that have a tendency to have vein abnormalities will have those abnormalities form in the veins that are created in the future. So your future will probably include more vein problems. So
I am learning so much. So you can regrow veins. So you have these ways. Now, this saphenous vein we talked about, is that usually the bad actor? Is that the usual one that goes first?
It is the most common one. The saphenous vein is a vein that runs from the groin to right around the knee down to the ankle.
Kind of in the inner thigh
Yes.
here.
Yes.
Okay.
Yeah, and one thing for people out there who are wondering, gee, how do I tell if I have a saphenous problem? There's two things you can do at home. One is to look at your inner ankle, and if you have a bunch of little tiny spider veins at your inner ankle, those are coming from the saphenous vein.
I'm looking right now, Michael. I'm dying to see.
Yes. Yeah.
There are a couple down there. Okay.
So you have saphenous vein reflux. That's the abnormal flow in that saphenous vein. So it's very common. The other thing is that there is it's something we call in our practice the Yelp sign, and it's not really described in the standard vein textbooks, but it's fairly reproducible in that it involves pressing on the saphenous vein below the knee. If you feel below your knee, there's a bone there, your tibia bone, and right behind it is the calf muscle. And the saphenous vein is the only place its location is constant, is right there. And you can press on it, and if the vein has inflammation around it, it will hurt. So you can press there.
I'm doing it right now.
Yeah. So for some patients, they will wince and yelp, and you know,
you call it the Yelp sign.
We call it the Yelp sign. Yeah.
I love it.
Often they'll say, "Well, no, that doesn't feel very good. That's uncomfortable." So it's not always quite that dramatic, but it can be. And that's the basis for that is inflammation around the vein from that stagnant circulation.
So, if you've determined the saphenous vein, the blood's going backwards, it's dilated, those normal flapper valves aren't working, is your usual treatment, you put one of those tubes down there with laser or electricity on it?
That has at least, it varies by the study, but 95 to 98% success closing the veins down. My personal practice between 98 and 99% success.
Because you're good.
Yeah, well, yeah, we're very careful who we pick, and we're also very careful with how we do treatment. So we want to make sure we have a good outcome. So a high success rate, and when that vein closes down, the blood reroutes. One thing that people need to understand, at least in my practice, is the recommendation around the country really is only to use that catheter from the knee up, and that's because the nerves come in close to the saphenous vein below the knee, and you can get numbness and tingling, and so it's not recommended to use that catheter below the knee. So below the knee, what I do is I will do an injection treatment. I'll find the veins with an ultrasound, numb the skin up, and put some solution in to seal the vein off in the calf. And that is kind of a complementary 1-2 punch, so to speak.
Is that the sclerosing foam stuff or high salt? What would you use, foam or salt? I know there's different things people have injected into veins.
Yeah, well, people have used a number
alcohol.
Alcohol is used more these days for ablations in the interventional radiology lab when they're trying to kill a nerve. But
in the heart.
No, in an area where there's pain. A pain doctor.
Like a permanent nerve block. Okay,
right.
okay.
Yeah. But the current solutions that are used are sclerosant detergents. They're called detergent class because
they're foam. They
turn into
foam.
Yes, and they used to use hypertonic saline. It's used less and less now. The reason being is it's has a higher risk of getting a skin sore from the hypertonic saline. It still is used in certain circumstances. And one of the advantages of hypertonic saline, or this concentrated saline, is there is no allergic reaction to it.
Right, because you've already got, it's just a higher concentration of what you already have.
It's basically salt water. So, so for some people, it is a good choice, but not many.
Okay, and you have all these options. So you essentially sclerose or ablate or block the offending veins.
Yes.
And how long does it take and you're doing it 98%, you're getting high reliability. How long does it take for someone to start feeling better, for this inflammation to go away?
Well, yeah, so that's, it to some degree depends on the symptom. And some of the symptoms that we kind of alluded to, cramps and restless legs. The cramps is remarkable. Cramps, the pattern with vein reflux associated cramps is that they always occur at night. They may also occur during the day, but they always occur at night. So when I hear the story that I'm having cramps at night, that tells me they probably have vein reflux.
Okay.
And the success rate in eliminating the cramps is approaching 100%.
How quickly, Michael?
Well, this is the other thing that's remarkable, and I've learned this from talking to patients. And usually they have cramps, once or twice a week, maybe a couple times a month. But occasionally I'll have a patient that has cramps every night.
Oh, they must be miserable.
Yeah, they're miserable because the definition of a cramp is it's painful. And those patients that are having cramps every night, what I've learned is when I do a vein treatment, the cramps go away that night in the leg we're treating.
I'll be darned.
And that is very reproducible. I mean, it's quite remarkable.
Wow.
Occasionally, it takes the second follow-up treatment, the injection treatment I mentioned, to get the full improvement. But those people are so grateful. And I know for myself, I've had cramps as one of my symptoms, and they miserable. And for me, so I've had a series of treatments over the years, because every couple of years, you have to get a kind of a touch-up. But one injection session and the cramps go away, and it's pretty remarkable. Yeah,
that is so dramatic, and boy, that puts a fine point on that. So
the other symptoms are a little bit variable, but usually within the first week, people notice improvement, and the fatigue is the one that takes. We tell people 3 to 4 weeks because they're healing from the treatment, which has some inflammation from the healing process. And the inflammation is what's causing the fatigue. And so when that all clears out at about a month, that's when people really notice it. So,
wow. So you have high success rates and rapid relief in many of these situations. Wow, that is just amazing. So is a Charlie horse, what causes a Charlie? I've had Charlie horses traditionally after coming back from a backpacking trip.
Sure.
You're in the car, you've been 2 or 3 weeks on your feet, and you get a cramp in the car.
Yeah.
Oh my God, there's nothing like it.
Well, no one really knows. I did come up with an intervention that I actually perform on patients, and I have a YouTube video about it. It's got like 500,000 views. But it's basically a self-massage method where you're massaging vigorously the tendons behind your knee.
Okay.
And the way I have understood it in my own mind of why does that work? Because it does seem to work in about 15 seconds. Because a cramp naturally will die out within 3 to 5 minutes when the energy source ATP is expended and lactic acid builds up, and the lactic acid actually paralyzes the muscle. So it will stop, but it takes minutes of pain.
Yeah.
So this intervention, in about 15 seconds, you can stop the cramp. But the way it makes sense to me is that method works by stimulating a tendon reflex, the Golgi tendon receptor, which you may think back to medical school. Do I remember what that is? It's a receptor in the tendon that protects the tendon from overuse. The tendon is the weakest part in the link between the muscle, tendon, and bone, where they are. So the tendon is the weakest part. So there are receptors in the tendon called Golgi tendon receptors, and when this is being stimulated vigorously, it is telling the tendon receptor, you're pulling too hard. Stop the muscle contraction. So I think it sends a reflex at the level of the spinal cord back to the motor neuron going to the muscle and tells the muscle to stop.
That's great practical advice.
Yes.
So you get a calf Charlie horse, you rub the 2 tendons on the back behind your knee.
Behind your knee, yeah. And those you have to. It has to be uncomfortable. I'm not saying painful, but it has to be uncomfortable.
You got to get in there.
You got to have it be uncomfortable, and you can pulse it. You can have it constant, and that is, I will be treating a patient and they get cramps in the middle of a treatment, and I'll reach over and do that, and the cramp goes away. So,
and how does fixing the venous reflux or this backflowing vein fix it? What causes it?
What causes it? Well, so that is a mystery no one has really understood. I would love to get involved in a research project, but what makes sense to me is that this pathway that I'm describing involves, kind of in medical terms, there's different neurons, and the neurons the neuron going to the muscle has a sensory neuron coming from the leg that is modulating or modifying how that nerve is firing. The muscle nerve is firing. And so there is some modification of the input from the leg from this inflammatory process.
Okay.
So in medical terms, it's an interneuron it's inhibitory, and that is being somehow affected by what's going on in the leg.
And they get better as the blood flow improves and the
Yes.
inflammation goes down.
So
Well, that's just fascinating, Michael. And it sounds like a lot of people are probably suffering needlessly.
yeah, I saw a lady this week, and it is astonishing. She has one of the most dramatic cases of what's called nummular eczema. Nummular is a description of it's simply a shape, and it's circular or oval, and her patch is about this big on her calf, and her main symptom it's brown discolored skin and flaky skin, which is what eczema is, and her main problem is it itches so much she can't sleep.
Itching. So it's a big. So for people who are just listening to this podcast, you put like a pancake size here patch. So it's a huge patch on her calf. It's discolored and it's horribly itchy.
It's itchy, and
We call it pruritus, but that's itchy.
Yeah, so she is having trouble sleeping. I mean, she's miserable, and she's had it for, I think she said between 12 and 15 years, and she's been to 8 or 10 specialists. And so when I saw her, and she has associated with that a giant cluster of big bulging veins on the kind of the side of that. But when you look under this patch with an ultrasound, which is what I do when I examine people with these patches, I look with myself with the ultrasound. There is a whole collection of abnormal enlarged veins right under the skin, which is that stagnant blood flow that's triggering the inflammation. She's going to get pretty immediate relief from her itching. But, what frustration that she's been through. I mean, my good gosh, for 12 years.
So that's somebody that runs into your office for treatment. Oh boy, I have a chance at relief.
Yeah. So anyways, so
tremendously gratifying. So Michael, are there any other vein conditions or symptoms that I haven't mentioned? Is there any other, as we wind this down, are there any things you would like our audience to know? Any other parts about vein disease or treatments that you would like my audience to know, our audience?
I would say that the one thing that is, the two sources of a missed opportunity to help people is they look at their legs and they look normal, or maybe a few little tiny twigs of abnormal veins. That's the most common pattern that we see that is associated with an underlying vein condition that is benefiting from treatment. The other is the problem with people getting fatigued and gaining weight and being told, look, you're just getting old.
Right,
That
or you're a
is-
slob.
yes.
You just eat too much.
Right.
Right.
Yeah,
Blaming the victim.
And so people gain weight, and those people really are, just so grateful to have their energy back, and they're able to get into an exercise program. In fact, those people are so psychologically debilitated because of that kind of process of chronic illness. When I see them, they have tried exercising, they've tried getting into walking programs. I actually tell them, and I'm probably the only doctor that does this, don't start exercising until you start your vein treatments, because as soon as they start their vein treatments, they all of a sudden begin to notice, yes, I'm feeling better, and we have them start on a daily walking program. After this, yes, because I tell them you're going to get so demoralized trying to exercise and get into shape until your circulation works.
Well, you're making it worse, aren't you?
Yeah.
Potentially.
So people wait to start until the vein treatments are underway,
and they heal up rapidly. We're
heal up,
talking
yes.
about like a week or so. They're ready to go, or a couple weeks.
They start the walking program the next day.
Next day.
Yeah, next
day.
day.
So you've sealed up that vein.
Yes.
And you're not going to bust it back open.
No, they start the walking program right away, and obviously, depending upon what kind of physical condition they're in, because some people have become, a medical term is deconditioned.
Out of shape.
Out of shape, yes. They're really out of shape, and
I know something about that.
Yeah. So they take a while, and I learned something from a patient once, and I saw her in follow-up sometime later, and I said, and she had lost something like, I think about 60 or 70 pounds. I mean, she was
Big chunk.
And part of it was an exercise program. I said, "How did you do it?" She said, "I was in such terrible shape." And I said, "How'd you get up to what she was working?" I think she was exercising 45 minutes a day. And she said every week she added 1 minute. And I thought that was a winning. I mean, for her, it was a winner. So
Yeah.
she added a minute a week and got up to 45 minutes within a year, and she lost a lot of weight. And so that's, rather than trying to do it all at once and,
Yeah.
overshoot.
In recovery from a lot of medical conditions, Michael, they say progress, not perfection.
Yes. Yeah.
Just make some progress every day. It seems to be a universal truth in almost every medical condition or psychological position you can be in.
I would agree. Yeah. Take it slow.
Take it slow. Don't beat yourself up, and get expert help. That's why I'm such an advocate for bringing experts on this show, so we can hear from the best and improve our lives on the way. Well, Michael, I want to thank you so much for your time. I've learned so much from you. If people want to look you up, it's called MissouriVeinCare.com. And you've got other YouTube videos that they can learn from. And this information, I think, is going to help a lot of people, Michael.
Yeah,
Thank you
good,
so much.
good.
What a pleasure having you.
My pleasure, Gil. Okay.